Thursday, October 29th, 2020. My name is Joe Doherty. I work for the Utah Department of Public Safety in the state's COVID-19 response. Our speakers today will include Governor Gary Herbert, Dr. Angela Dunn, the state epidemiologist, Rich Saunders, the director of the State Department of Health, Greg Bell, the president and CEO of the Utah Hospital Association, and Dr. Mark Shaw, also with the Hospital Association. Governor Herbert.
Well, thank you, Joe, and welcome everybody to our weekly press conference update on particularly COVID-19 and the pandemic. We appreciate you tuning in, and we appreciate the press and helping to expand our areas of influence with the information we're giving today. We know that the pandemic is very disruptive in our lives. It's getting old. People are getting tired. We're getting frustrated. We're getting angry. We're getting depressed. We wonder when this is going to end. And we certainly find ourselves in a serious situation. And we've never done it before, so we're kind of learning as we go. We appreciate the willingness of the people of Utah to, in fact, modify their behavior as best that they can so we can slow down the spread of the coronavirus. Unfortunately, we're in a very difficult time right now with these surges and these spiking that's going on with the infections and the coronavirus. And we're concerned, as we've said 7.5 months ago when we started this quest, the number one issue is let's make sure we don't overwhelm the medical system. We saw that happening around the world. Italy comes to mind and others. We saw it happen in New York. And what that resulted in is the highest mortality rate of any place in America. So we don't want that to happen here. And we're very concerned about the direction that we're going right now. And we could have a crisis of care if we don't, in fact, bend the curve on the infection rates that's going so high now. So that's part of our emphasis here today. The hospitals, frankly, just can't keep up with the trend that we have going now as more and more people are going to be demanding hospital care. Let me just mention a couple of things. I know this sounds like a broken record. We say it so often, it's become a cliche, and I'm afraid that people's eyes just kind of glaze over because we've not said really anything different from the very beginning 7.5 months ago and what we're saying today. Until we get a vaccine, there are certain behaviors that we ought to, in fact, modify, and it's not what we're used to doing. It's something that's strange and something that's hard to do. One is social distancing, being apart at least by 6 feet. The wearing of a mask when you can't social distance. The evidence is overwhelming that does help us. It's not a cure-all and not a be-all, but it does minimize risk. And as we have this infection taking place, we all want to minimize risk to ourselves and to our family and our loved ones and our friends. So social distancing and mask wearing should be something that we are cognizant of and try to do each and every day of our lives. And the good thing about wearing a mask, by the way, which is no longer just a pleasant request, this is now a requirement based on our Utah Health Department's health order to all of us in most of the state. At least 21 states or counties today. All of them are along the Wasatch Front. And the good news is it's something that we can do that does not have any negative impact on the economy. We don't want the cure to be worse than the disease. And so let's make the best of the situation and try to live our lives as normal as we can. Now, part of the challenge right now with this spike is that for a temporary period of time, we hope it's temporary, that we're going to ask you to limit your social distancing, your social gatherings rather, to, in fact, 10 people or less. I know that's not something, if we have holidays coming up, whether it be Halloween and Thanksgiving, we might have to find different ways, in fact, to celebrate those holidays with our friends and our family members. But it can be done. And again, that will help us get past this surge that we're having right now. It'll help us protect people's health and their, in fact, increase or decrease the mortality rates that would otherwise increase. So those are things we're asking everybody to do. And I know it's not much different than what we said 7 months ago, but it's just as true now as it was then. And so we need to solicit everybody's help. So today, as part of our efforts, we're going to first hear from Dr. Angela Dunn, our state epidemiologist, and she'll provide us with an update on the cases of today and some counsel there. And then after that, we're going to hear from our Health Department Director, Rich Saunders. He'll share additional information on our public health order currently in effect and some of the new programs we have in place. We'll go to that point. Dr. Dunn?
Good morning. Today, we are reporting an increase of cases of 1,837. Our 7-day rolling case average is 1,578. This is an increase from last week when it was 1,289. And our 7-day percent positivity is 18.1%, another increase. Last week, it was at 15.5%. We continually are looking at our hospital utilization as a key metric to try to protect. And our 7-day rolling average of ICU utilization across the state is at 72.6%. However, our key referral hospitals continue to report higher occupancy and a high strain on their healthcare providers. I'll now turn the time over to our Executive Director, Rich Saunders.
Thank you, Dr. Dunn. And thank you, Governor. 2 weeks ago, we announced the creation of the Transmission Index. It's the data-driven system that provides guidance to counties based on the rate of COVID-19 spread and hospital capacity. You can see it at coronavirus.utah.gov, and we're displaying it on the screen now. It's a very simple system. By public health order, if you live in a high transmission area, you're required to wear a mask anytime you're around someone who doesn't live in your same household and 6-foot distancing is compromised. Also, social gatherings, as the governor mentioned, with family and friends are limited to 10 people. The vast majority of the state and all counties along the Wasatch Front are in the high transmission area. In those areas, masks are required, and social gatherings are limited to 10. Counties are designated as high, moderate, or low using the data that is seen on your screen. Today, we're bringing to your attention that 2 more counties have moved from moderate to high. Uinta and Duchesne have moved from moderate to high. They're joining the rest of the counties that are in high. That brings the total to 23 counties in high, 1 county in moderate, and 5 counties are in low. In a few minutes, we're going to hear from some of our hospital representatives, the Utah Hospital Association. And the message that they're going to be delivering is pretty sobering, but it reflects the reality that they're currently facing in the hospitals. And we feel like it's really important that people understand this message, as Dr. Dunn and the governor have stated. It's not just about COVID, it's about anyone who has an issue that takes them to the hospital. A heart attack patient, for example, that might not be able to get into the hospital quickly enough for treatment. It's about patients waiting for hours and hours for an emergency surgery or emergency care. It's about the basic kinds of care that you would expect to be able to receive by going into a hospital. But these are becoming severely strained and at risk. Now, our hospitals are very diligent and they're very capable, doing an amazing job, and they still continue to care for patients. They're stretched very thin, and we need to join together to help alleviate this problem. The simple behaviors that are outlined in the Transmission Index are the things that we can do together to help make the needed difference. Thank you very much.
Thank you, Rich and Dr. Dunn. Throughout this pandemic, we've tried to, as a state, work with our state health department, working with the legislature, our business community, the the regional health departments, people throughout the state in all 29 counties and 248 cities to get the best information we could, to get the best thinking we could. I liken it, if I had some leaky pipes, I would want to contact my plumber and get his advice of what we need to do to fix that problem. If I'm looking for financial advice, I would want to talk to my banker, my accountant, who knows those issues, can give recommendations as far as what I should be doing with my financial situation. Likewise, if we're concerned about our health and our health care, we ought to be talking to our doctors, our medical experts, our scientists, particularly in this pandemic, to get the best advice that we can to know what we should be doing as a population to, in fact, defeat this pandemic and at least make our way to navigate through it so we have minimal risk to our health care, our health of the people of Utah, and also make sure that the economy continues to stay open, because that's another issue that we want to make sure we protect. And so in doing so, we've got the best thinking from all those different sectors and the overwhelming majority. That doesn't mean there's not some difference of opinion out there on what we should be doing or what the truth is. We're trying to make sure that when you tune into the state, that you get accurate information. I believe that most people, if they have accurate factual information, will in fact modify their behavior in their best interest. And so we want to make sure that that's what's happening today. Last week, my team met with the Utah Hospital Association and the chief medical officers from the different hospital groups throughout the state. And they shared some very sobering information to us, and causes us all to be concerned. And I think it will cause you to be concerned too, as we bump up against a crisis situation, which we wanted to avoid from the very beginning. But we're getting perilously close here today. So our hospitals really are getting too full to function as efficiently and effectively as they have in the past. That should cause us all concern, not just for COVID-19 patients, but for those others who have a variety of different conditions and situations that they need an ICU bed unit. And they need the expertise that comes with those who service those hospital beds. So with that, to speak to that issue, we have got Greg Bell here, who's in fact, the President and CEO of the Utah Hospital Association, and also Dr. Mark Shaw, who's going to talk to us about the crisis standards of care that we're kind of bumping up against. So, Greg, first you, and then Dr. Shaw.
Thank you, Governor. I'm honored to be here today to speak to the people of Utah. Kudos to the Governor for your steady, firm leadership over this long time that we've been dealing with the pandemic. We're grateful to the people of Utah who have been supportive, and especially those who have been compliant with public health advice and orders to restrain the spread. We are in the middle of a very serious spike. We have a pandemic. We don't use that word out of this context often, but we are in the midst of a pandemic, and it is now virulent among us. As we assess hospital capacity, we have since day one been concerned about our excess capacity. We build hospitals to the norm, to the usual pace of what our patient will require: heart attacks, stroke, end-stage kidney failure, cancer, operations, trauma, et cetera, et cetera. When you layer on top of a very efficient system in the state of Utah, another 20 to 25%, perhaps 30% of patients who need very critical, intensive care, then that strains and could overstrain our resources. In preparation for events like this, like a major earthquake, a mass shooting, a pandemic, the Utah Hospital Association, under contract with the state of Utah, has prepared crisis standards of care, meaning if medical resources, ICU beds, staff, drugs, supplies become so short that we need to allocate or triage those resources, you want to do that in a fair, humane, ethical way so that no one is disadvantaged, so that the disabled, the healthy, the old, those with underlying conditions are all treated on a similar basis. And so we have long prepared these crisis standards of care. And I have with me today, at the governor's invitation, Dr. Mark Shaw, who's been the chair of the Utah Hospital Association's Crisis Standards of Care Committee. Those standards have been revised to reflect the pandemic last spring under the governor's direction. They've been submitted to the governor and to the Department of Health. We warned the governor last week that in view of the increase of cases from in the 800s and 900s now to the 1200s, 1500s, and today a rolling average of about 1600 over the last 7 days and a daily rate approaching 2000, that we know that in 7 to 10 days, 2 weeks, cases will end up in our hospital. So today with us is Dr. Shaw, who will explain the contingency planning that we will exert to forestall any invocation of the crisis standards of care. But in that event that we should have to invoke them, then how those will be triggered, and especially what those standards mean for the people of Utah. Dr. Shaw.
Thank you, Lieutenant Governor. Thank you, Governor, for your leadership. My name is Mark Shaw, and I am an emergency physician. I've been working in that role for about 20 years. And through that career, I have developed expertise in disaster response as well. I've traveled around this country and around the world, helping communities through disasters. And I have utilized what I've learned through those experiences to help further our preparedness here in the state of Utah. I'm going to be talking to you today about crisis standards of care. And to provide context around that, I'm first going to talk to you a little bit about supply and demand relative to healthcare capacity. The demand, of course, that we're speaking of is as Greg accurately said, is both the normal patient care that we see on a regular basis, both within and outside of a pandemic, heart attacks and strokes, patients suffering from traumatic injuries, those requiring emergent surgeries. But then on top of that is layered patients that have coronavirus. About 5% of patients will end up requiring hospitalization. That, of course, becomes more likely as patients are older or if they have comorbid conditions. And 20% to 30% of those patients that require hospitalization go on to require intensive care. And oftentimes that hospitalization and that provision of intensive care is for prolonged periods of time. And so the demand becomes significant, as you can see on the slide. As that solid line grows, we start to butt up against the dotted line, which represents supply of care. Now, as Greg again said, our supply of care is predicated upon what is normal. We do have an efficient healthcare system, and that efficiency has a downside. When faced with disaster, when faced with increased demand for care, we understand that healthcare capacity is finite, that it is not limitless. And the closer you become to that inflection point, where the demand for care is greater than the supply of that care, we enter what is called contingency care. We move from conventional, normal operations to contingency. We also need to recognize that supply of care is a constant push-pull. It changes hour to hour and day to day. As you see on the slide, the dotted line actually diminishes during the pandemic because our caregivers live in our communities and they are exposed to coronavirus in ways that normal people are exposed. And so our caregivers sometimes can't come to work because of exposure or illness, or because they have family members that have been exposed or are ill. And so not only is our supply of care predicated on normal operations, it actually can, in many ways, be further diminished below what is normal because of the intrinsic effects of that pandemic. Let's talk a bit about contingency care. For years, we have worked on how to better provide care even when our capacity is limited. And we have doubled down on these efforts over the last 7 months. I have been in this field, as I said, for 20 years. I have never witnessed a deeper degree of collaboration and hard work around these contingency strategies. We have nurses taking care of more patients than they do ordinarily. We have nurses who are having to work mandatory overtime. We have been benefited by the hard work of our community members in the Million Mask program. We've worked hard to deliver adequate PPE to caregivers so that patients and caregivers can be safe. We have contracted skilled nursing facilities to take care of COVID-positive patients so that we can offload hospitals appropriately when it's time for patients to leave that acute care setting. We are actively working with the state and across all systems to actively recruit nurses from not only within our state, retired and semi-retired nurses, but also around the country. And we have had success with that, but we still can't fill all of the needs. We've worked closely with the Division of Public Licensing on waivers. The state is working hard to encourage all of you to get a flu vaccine. We appreciate the new restriction guidelines from the governor's office and moving appropriately in a targeted fashion more and more counties to a mask mandate. We are doing load balancing between hospitals and across healthcare systems such that we are, in a way, diverting patients away from hospitals and systems that are most stressed, that have the least capacity, towards those hospitals and systems that have more capacity, so that we can continue to ensure a high level of care. We are expanding ways of taking care of patients to include home care and alternate care sites. So perhaps there's a segment of patients that are sick enough to normally require hospitalization, but perhaps we can safely take care of them out of the hospital. We're developing programs to do that, to include remote patient monitoring using up-to-date technology. We are putting caregivers in extension roles, meaning that perhaps they are working outside of their normal scope of practice. Perhaps they are working when they have not worked for some time. We're putting them into functional nurse or extended roles where they have folks to work with, folks to mentor them, folks to supervise them, but then we can increase our capacity. So the work is hard, it is endless, and we embrace it. We don't shy away from it. But despite those best efforts, healthcare is still finite. These contingency efforts may fall short. They may not meet the demand of patients if this community spread goes unchecked, which brings us to crisis care. That is that donut hole on the slide where we have a supply and demand mismatch. And let's be frank about what that means. That means that patients, COVID and non-COVID patients, may not have access to the care that they normally would because there is simply not enough of it. And that means outcomes that we try our hardest to avoid. We need to understand that we are forced into crisis care. We don't fall into it because of our choosing. The only choice we really have is how we respond to it. I have worked under crisis conditions myself, and I understand firsthand the negative impact it has on patients and also on providers, myself included. We do not want to go into crisis care blindly and then expect individual providers to simply do the best they can. It'll lead to inequitable care. It'll lead to worse outcomes than if instead we plan for it. And that is what crisis standards of care is. It's an acknowledgement that crisis care is a possibility, if demand outstrips supply. And it's an acknowledgement that planning for it is better than simply hoping it does not occur. It provides a set of guidelines that have been developed over years and refined over months through expert consensus from physicians from many disciplines, including intensive care, trauma, emergency medicine, and also others that are expert in things like ethics and palliative care and emergency management. And these guidelines are then further shaped through public discord. They are intended to be transparent. They are, in a way, a shared covenant that we make. Healthcare providers fall under those same guidelines. It is simply an acknowledgement that in times of scarcity, we need to do the greatest good for the greatest number. We need to ensure that we avoid unfair bias. We need to ensure that care is targeted to those that we think are most likely to benefit, regardless of disability, race, socioeconomic status, and so on. And when I speak about refinement over the last few months, that has included a collaborative work with the Department of Health and Human Services at the federal level, the Office of Civil Rights, to help really transition us away from how we used to think about crisis standards to include decisions around long-term outcome, to really now a focus really exclusively on short-term outcome, meaning what are the patient's chances with and without intensive care to survive this acute illness, and really has moved us away from further disenfranchising those that are most vulnerable, and really, really proud of that work. So, and I also want to emphasize that the crisis standards are very patient-focused. They start with goals of care. This is something that's important every day. The most care is not always the right care, and that we want individuals to have ownership over how they would like to live their lives, in particular, if they are later in their expected age. We want them to be the director of what they think is best. We want to have them maintain that autonomy and empower them to share that with us. So goals of care is front and center, not as a resource allocation, but as a patient-centered shared decision-making piece. It is always regrettable to provide care that a patient does not want. It really becomes a tragedy to provide that care when your resources are limited and you end up not having that care then available to someone who does want that care. So really want to emphasize that goals of care front and center and separate from triage decision making. And then the crisis standards of care moves on to an objective way to measure short-term outcome that is further informed by, number one, individual patient assessment, and number two, ongoing assessment of our capacity. We recommend utilization of what's called a crisis triage officer, a physician who gets expert training and guidance around crisis standards so that they can be the decision maker, removing that decision from individual providers and individual nurses, instead to that CTO role to ensure proper application of the guidance, and also that that guidance be applied fair and equitably, not just across a single hospital, but across a healthcare system and indeed across the state. We do not want the patient's provision of care to be dependent on factors that are not important, like where they happen to be located, what they look like, and so on. We want this to be fair and equitable. So that is crisis standards in a nutshell. I want to close with trying to answer the question the governor posed to us last week, is what can we do? I want to explain to everybody that crisis standards is a possibility. It's one that we plan for, but it's also one that we try hard to avoid. We have made a choice. Everybody in this room has made a choice to unify around a common goal, and that is to empower and enable Utahns to help Utahns get through this pandemic. And you each have a choice to make as well, to unify around this mission. We can continue to argue and disagree about lots of things, politics and sports, upcoming election. We cannot continue to argue about masking. We cannot continue to argue about whether this pandemic is real or made up. And we cannot continue to argue that healthcare will do just fine regardless of the demand. That is not true. So let's unite around this shared mission. Let's do what we can. Yes, it's uncomfortable. Yes, it's strange to wear this mask. Yes, our Halloween activities this weekend will need to be altered, but they can still be enjoyable. Kids are resilient. We are resilient. Let's unify around this. I hope that you can make the right choice to unify around this message. Then all the little choices become much easier once we're clear in our mission. Thanks for your time, Governor. Thanks for everybody's time. I appreciate it.
Thank you, Dr. Shaw, and thank you, Greg. We appreciate your information that you've shared with us here today. Most of it probably not surprising as we think where we've been and where we are today. The information that we've given to our fellow Utahns here today is sobering, and it should be as we see the challenge we face now going forward. We've tried to be transparent and forthright from the very beginning. We've said to the people of Utah, one of the things we must avoid is the overwhelming of our hospital and our medical system. And we know that the consequences of that are dire if we, in fact, allow that to happen. And clearly, as we see the numbers today, we're just far too close to having that occurrence to take place. By the way, I'll just add to the discussion that this is not unique to Utah. We have 31 states at the latest count that are having the highest case counts that they're having in the history of the pandemic here in the United States. We see other countries now starting to have resurgent and trying to shut down their communities. And we don't want to do that. We want to, in fact, navigate this so that we protect health, but also protect the economy. We're trying to find that optimal balance. There's way too much debate. I appreciate Dr. Shaw talking about the time for the debate is over. It's just more time for action. It's what we're doing. I appreciate the fact that our mortality rate right now compared to the national average is 5 times higher than the mortality rate here in the state of Utah, something we can take some encouragement from and appreciate the work of the people of Utah, and particularly the work of our medical experts in what they're doing to make sure that we get good health care and have less severe reaction to this COVID-19 virus. But it's time for us to understand not only the mortality rate is an important issue, but the long-term ramifications of those who have the COVID-19. We don't know all there is to know about this. The science is not clear. What we do know, though, is there's ramifications for people with heart and long-term ramifications, autoimmune system, the loss of a sense of smell and taste. I've mentioned before my granddaughter, who was 13 years of age, now has not recovered her sense of smell and taste. In fact, smelling food makes her nauseated. And consequently, she's now losing weight as a 13-year-old teenager. Those are some of the long-term ramifications that we've got to be concerned about. It's not just mortality, it's other aspects of this pandemic, this coronavirus, that we need to, in fact, understand. Last but not least is probably what we're talking about today. It is a time for Utahns to really lengthen their stride, to find out what we can all do in our respective spheres of influence to make things better. We all have roles to play. We can do things better. We certainly know the plea that's been made, and we have now a requirement. It's not just a pleasant request. We have now a health department order that requires us to wear masks when we cannot social distance. Social distancing is good. But if you can't do that, then you should be wearing a mask to minimize the risk of sharing the coronavirus or catching the coronavirus. It does have a major impact in reducing risk. Not a silver bullet that eliminates all risk. There's no way to eliminate all risk, but it does help us minimize the risk. Again, we're asking to do something that, again, is uncomfortable. When limiting your social gatherings, particularly those casual gatherings with friends and family, to keep the 10 members or less, that will help us still be able to socialize to some extent, but help us slower the spread of this coronavirus amongst the people of Utah. So we thank you for your cooperation. Our hospitals are filling. We need to, in fact, do what we can to bend that curve. It's going to take all of us, again, as Dr. Shaw's talked about, of pulling together. We can't do this with just a divided population. We need to all get behind this effort and do our part, pull together and support each other and encourage each other to do better and to lengthen our stride as we work together to fight this pandemic. And if we'll do that, I'm confident we're going to come out on top. I think we can turn this around before the end of the year if everybody pulls together. So with that, we'll take some time to take a few questions.
Hi, thank you. Governor, we've had literally hundreds of reports now of businesses and places of public gathering not enforcing the mask order under the new guidelines. And now we're getting some reports of businesses aggressively flouting it. I know you keep saying that masks are important to public health and safety, but lots and lots of people aren't wearing them here. You keep saying that you don't want to talk about enforcement because Utahns should be, like, I guess, valorous enough to use them out of the goodness of their hearts, but people aren't wearing them. So I guess my question is, if masks are actually important to the public health and safety, why are they less deserving of enforcement than all the other laws and regulations we have? People get ticketed for speeding, they get arrested for drunk driving, businesses get shut down for building code violations, restaurants get cited if their kitchens are too dirty. And we have, I don't know how many nonviolent drug offenders in prison. So why are masks different if they matter to the public safety? If not as the Class B misdemeanor, which involves, as I understand it, a lot of, it involves prosecutors and maybe not as simple as, a health officer issuing a citation, then, as a regulatory one for businesses like any other health and safety rule.
I think I understand the question. One, let me just mention to the private sector has been very good at putting in place mask requirements and social distancing.
I mean, a number may have been, but we're hearing that a lot are not enforcing it, and that when asked about it, employees are saying, well, we just get screamed at by the customers if we try to enforce it.
Let me try and answer the question, Aaron. Thank you. Most in the private sector are doing a great job. We don't find the spread of the coronavirus and our local business establishments. Business people understand they've got to keep open. They've got to provide a safe place for their employees to come and work. They have a safe place for their customers to come and shop. And so we don't see a great spread taking place in our business community. I think there's only a few in comparison to the thousands of businesses that are out there that are flaunting it, or actually taking an aggressive position in opposition. Some are. That's unfortunate. Under our system, the enforcement of these requirements to wear masks are done by the local government enforcement folks, so the local county sheriffs, the local police departments, and certainly the discussion is ongoing about should, in fact, we step up enforcement. That's certainly something that's on the table. But we've allowed that to be taking place at the local government level. This is not an easy thing to enforce. As you drive down the road, you talk about people getting tickets for speeding, but how many get ticketed? How many are actually speeding? It's a small percentage of those. So again, that opportunity for us to have enforcement, we'll be working with our local government officials and the local health departments to see if in fact they can step up that enforcement mechanism. That is their responsibility. It's been hard for the state, in fact, to do this on a statewide basis with our highway patrol. Just wouldn't work. So it's got to be the local governments that in fact put that enforcement mechanism into place. Next question.
Hey, this is Michael Locklear with 2 News. I'd like to hear from Dr. Dunn, and maybe the governor can weigh in as well. Dr. Dunn, we know you've been the target of protesters, and I'm just wondering, how are you doing?
So I have been made aware that there were protesters at my house this morning, and it's scary and wrong that somebody would feel comfortable sharing my personal information. It's taken a really big toll on my family and myself, and they're supposed to be there again tonight. I think it's really unfortunate that we live in a state where people feel that it is okay to harass civil servants. It's wrong. So I don't know what else to say about that.
I know we're asking a lot of the people of Utah to be patient. We know that their time is valuable. I would hope that they would put that in a constructive effort. Protesting Dr. Dunn at Dr. Dunn's home is probably not the best use of their time. We've had protests at the governor's mansion, here at the Capitol, at my home, my personal residence, and again, I don't know that it's really making anything different or better. I think there's much better ways to utilize your time, and I would encourage people to be productive. Follow the advice of our medical health experts. We have the business community out there having to stay safe, to stay open. Clearly, if we want the economy to continue to perform as well as it's doing, by the way, we're one of the best performing economies in America today. We need to make sure that our businesses stay open and stay viable. Our faith-based leaders have jointly gathered together and say, please follow these protocols that have been outlined by our best minds, our medical advisors, our scientific advisors. We have the best information available out there. But at the end of the day, it'll only work if people, in fact, modify their behavior, whether it's by government fiat or by just concern and love of your fellow man, which ought to be the number one driving force. I think we all care about our families and our friends, and we ought to care about our own personal health. So again, protest is part of America and our First Amendment rights. We would hope people would do it responsibly and engage in more productive opportunities.
Hi, Governor. This is Wendy from the Deseret News. I've heard Dr. Dunn and others say that a high percentage positivity rate is an indicator of even more rampant and unaccounted for disease throughout the community. Could she or someone else explain this a little more, and what it means and how that number points to more undetected cases that we haven't even heard about?
Sure. Dr. Dunn?
So percent positivity is, of course, the number of people who are tested in the denominator and the number of people who test positive in the numerator. So when we get upwards of 10, 15, 20% positivity, that means that there is a lot of spread in the community and that you're likely not catching everybody who has the disease because of the spread. When you get into percent positivities of around 3 to 5%, while you're still testing, 7 to 10,000 people a day, that means that you're testing enough people to identify everybody who has it and that you have control of the virus. So right now, as a state, we're at 18% positivity. In some younger age groups, 15 to 24-year-olds, we're over 20% positivity. That is very concerning that we aren't catching everybody who has the disease. Therefore, our number of cases is likely higher than we're identifying, and spread is harder to control.
Let me just add that we are going to take a review and over the next few days to see what we can do to enhance testing opportunities. Working with the legislature, again, we think everybody that really wants to get a test should be able to get a test. We're not to that point yet. We have symptom requirements and other issues if you've been exposed, et cetera. But we think more testing is going to help us, in fact, isolate. Our contact tracing efforts need to be expanded so that we can, in fact, isolate those who have got it so we can slow down the spread. So a big component part of what we're going to probably do better as we go forward is in our testing and contact tracing. Next question.
Hi, Governor. It's Ben Winslow with Fox 13. I have a question more for the Hospital Association and Dr. Dunn. So under this scenario with crisis standards of care. How long do we have, basically, between now and then with these skyrocketing case numbers? We're at 1,800 today. We've been at 1,900 last week. How long do we have before our hospitals are truly overwhelmed and you have to start deciding, really, who lives and who dies?
Okay, Greg and Dr. Shaw, you can handle that one.
Well, no one exactly knows because of the demographic who get ill. We are a lagging indicator in the hospitals, usually 7 to 10 days for disease to mature and for people to show up at the hospitals. We don't exactly know. To some degree, the people of Utah control this because if they were to intervene and seriously mask and distance, they could slow the spread significantly. However, I will tell you that our referral center hospitals, 16 hospitals along the Wasatch Front, who have the capacity to handle complex cases of COVID, and the hospital in St. George are what we call referral center hospitals. We have a wonderful rural network of hospitals, but typically they will refer complex cases, COVID and otherwise, to these referral centers. We have 453 intensive care beds plus a little bit of contingency capacity. Right now, the university, as you've seen in the news, runs between 95, 98% full. They're brim full. Intermountain Medical Center has been quite full. A hot spot to watch is St. George. Given the demographic in Washington County, with this kind of spread and with the age group there, that is something to be very, very concerned about. Otherwise, our other systems, and this is a system of systems with lots of cooperation, with load leveling among system hospitals and between separate systems. Stewart Hospital has 15 or 20% capacity. The HCA Mountain Star system has had somewhat more capacity, but we have less than 100 beds to hit that 453 number. And so car accidents, heart attacks, strokes continue to occur. That's usually 70-75% of the patients we treat. And so the COVID number, if it expands in the next 7 to 10 days by the amount of spread proportionally, then we could well be up against maxing out our system. But I don't want to be misunderstood that we're raising the red flag here. We're just issuing a warning that we don't know, but there is certainly a foul wind, and we need to take every precaution to avoid the worst case.
If I could just add some additional nuance to the answer to that, although I agree with everything that's been said. You know, I'd like to maybe move the focus a little bit away from invocation of crisis standards and a little bit more towards what contingency care means. Contingency care does not just represent a lot of hard work by hospitals and healthcare systems and by our elected leaders to try to increase our capacity for care and also to flatten the curve. This contingency care comes at a cost. As you ask nurses to work overtime, as you ask them to take care of more patients than they normally do, as you open up ICUs in areas of the hospital that are not set up for an ICU in the first place, as you dial down surgery, this impacts patient care. Patients may experience delays in care, whether they have COVID or not. They may have to forego a surgery that they've been waiting for months for a debilitating condition. They may experience a transfer away from family and friends because their local hospital doesn't have capacity, and which means that they are now going to be several hours away. And so this doesn't represent a simple change from normal high-level care to suddenly crisis care. There's a gradual degradation, if you will, if we allow community incidents to continue to grow, and in particular, when that incident starts reaching our more vulnerable populations and we see more hospitalizations, in particular ICU admissions. So difficult to answer, as Lieutenant Governor Bell said, but there's a gradual degradation that occurs. It's not just an on and off. Thank you.
Let me just add too, as I've had the opportunity to meet with our experts in the different hospital associations and groups throughout the state, their goal is to make sure that everybody, no matter what their circumstances, whether they're a COVID-19 patient or some other issue that brings them to the hospital, and particularly the ICU units, is to give the best care available at the time to that individual. And I know that's their commitment. But it is, Ben, as you probably know, a math problem. You know, if you have one doctor and a nurse for 5 patients, it's a little easier to provide quality care than if you have one doctor and one nurse to 10 patients. And so that's just the finite number of doctors and personnel we have available compared to a growing number of patients. So there's no denying the trend. And that's why the voice of warning that you're hearing today is we've got to bend that trend or we're going to have a problem in the future. Next question.
Thank you, Governor. This is Chris Reed with St. George News, and good to hear from you. A few Southern Utah-centric questions here. In the transmission index today, the one county that is staying moderate is Iron County, which does border the St. George area. And considering all the talk at this press conference of hospitals basically being at capacity, of the need for everyone to, the frankly dire situation, some would say, what would you say to people who say basically because Iron County is moderate, their mask mandate or their mask requirement is becoming a recommendation? So is it the right thing to tell people in Iron County, you know, you don't have to wear your mask. You can if you feel you should. Is this the right time to do that? And I also, as a follow-up, I'd like to, Mr. Bell, if he can explain a little bit more why St. George is a hotspot.
First, let's have Rich come in and address the issue on the mask requirements. I don't know if he's out in the ante room there. Did you hear with the question? Okay, talk about the new program we have in place, the transmission rate, and we have Washington County is in more severe transmission, high transmission rate, as opposed to
Iron County is moving is in moderate, so they wouldn't have the requirement.
So.
Yeah, so if I don't answer the question, please repeat it. The jurisdictions that we've used are based on county level. That's the smallest jurisdiction and a reasonable jurisdiction that we've chosen to be able to establish boundaries around these metrics. And Iron County simply falls under the moderate level based on their transmission or the percent positivity, as well as the 14-day case rate. So it's simply data that we have chosen. They fall into that category, and so that's what they are in at the current time. They actually have fairly decent numbers relative to the rest of the state. Hopefully they'll move in the right direction. As far as the mask, the directive that went out last week, is that the question? The directive that went out last week that all moderate counties should be wearing masks when in public settings within 6 feet of other people, as well as the social gatherings less than 10. That does end at the end of today. So I
guess my question is this the right time to do that, considering Iron County certainly is served by, for example, Dixie Regional Medical Center, which is at a surge ICU at this point. Is this the time to be telling people there you're not required to wear masks?
Yeah, well, we hope that people will wear masks anyway. At any type of public gathering, they would be wearing masks. Any of the workplaces, employees should be wearing masks when 6-foot distancing isn't feasible. And we would hope that people would wear masks just out of the common good of the whole. But we've set the guidelines, and they're within the parameter of moderate. And
I think the microphone is conked out there.
wow, that was NASCAR indeed. Yeah, so I think the bottom line is when counties reach those thresholds, we want them to be able to move into those behaviors and be rewarded and be aware that, the transmission there in that particular area is less. But we always want, based on the statewide transmission level, we always want people to be very conscientious of the principles that we've shared over and over again. But so I don't know what else to say other than we're trying to use the system the right way, and that's where Iron County is, and that's good on Iron County.
Thank you, Rich. Again, we're trying to put the incentive in the right place, and if people modify their behavior and improve the case counts, they'll be reduced to a lower transmission rate, which is what we want to have. We want everybody in the state to be not moderate, we want them to be in the low category. So, and frankly, if we all modify our behaviors, we can actually achieve that goal. One last question. If there is no other question,
I got one. This is Paul Nelson with KSL News Radio. Can the hospital, somebody from the Hospital Association, kind of break down who might not get the treatment if we do have to invoke that crisis standards of care? I mean, give some examples of people who would not be able to get the treatment that they need.
Dr. Shaw?
Thank you, Paul, for that question. The guidelines are focused on individual patient assessment based on short-term outcome. So meaning that if we are indeed in crisis, if indeed there is inadequate ICU capacity, despite every effort to identify the needed capacity, and if a patient is thought to potentially benefit from ICU care, and that is consistent to what their own goals of care or their family's goals of care are, then that patient's condition will be assessed using a combination of an objective scoring system, which includes measurement of organ failure, combined with individual assessment relative to the available capacity. This is done by someone specially trained in the crisis standards of care guidance in conjunction with the treating providers. So it's short-term outcome focused. We've moved away from more blanket categorizations of patients that would not qualify for ICU care, but instead have focused on assessment of short-term outcome relative to capacity and relative to other patients. I hope that answers your questions, but there really are not any categorical exclusions, except for really small numbers of patients that really have an illness that is what we'd consider end stage and futile, meaning that they would not be able to survive even given maximal care. And that's a really short list. Thank you.
So it's based on severity, a lot of it?
It's exclusively based on severity of illness. And it measures respiratory status through oxygenation, blood pressure status, and liver, kidney failure as well as neurologic status, again, combined with expert clinician individualized assessment, but it's absolutely short-term outcome focused.
I'll just add too that those decisions are being made now before crisis. We have a lot of families working with their doctors. The individual decide whether we continue on with treatment or in fact we just let nature take its course. So we're trying to avoid those kind of complicated decisions and leave it to not a crisis mode of decision making, but just a regular everyday aspect of healthcare. With that, let me just conclude by saying we thank you again for your participation today. We appreciate the media here and helping spread the information. We clearly are in a battle of this pandemic, and I hope we all remember that we're in this together. It's not one side versus the other. It's all of us working together to, in fact, win this battle over the COVID-19 and this coronavirus and this pandemic. I know that we want to pull together. We need to support each other. We need to find ways to come together in a united effort, in fact, to get on top of this spread. I know we all need to find ways, as our business community is doing probably a very good job, to adapt, innovate, and then to conquer in this battle. Right now, our biggest challenges really are casual associations one with another, whether it's be our young people getting together after a football game and doing things that aren't structured, not supervised, whether it's our getting together with friends and family. So we need to be a little more careful, unfortunately, as we have that time of year. We still can have a good Halloween. We can still have a good Thanksgiving. We may have to modify our behavior just a little bit. But as we do